Hi guys, good afternoon to you all. I'm Bessa from Portugal, and I'm very glad to be speaking at the International Academy of Ceramic Implantology. It's a great honor, and I would like to thank to Sami for the invitation and say that it was really a pity that I cannot travel and I can't be there with you guys. So I will make this lecture online. So I come from Porto, which is the second biggest city in Portugal, and North Clinic, it's my clinic, where we try to deliver eye-hand dentistry with a biological focus and utilizing only the best and the most biocompatible materials in the market. We have as well an educational center. So if you guys want to join us one day for training in hard or soft tissue management for ceramic implants, be my guest, just please write us an email and we will answer as soon as possible. So my topic for today is the full digital workflow using the monoblock ceramic implants. And the monoblock ceramic implants, they have some specific considerations that will take care of enlightening during this presentation. Biology and technology, they should work together. And this famous sentence from this genius that was Steve Jobs, the biggest innovation of 20th century, 21st century will be the intersection of biology and technology. I couldn't agree more, because only with technology you cannot do many, but if you add technology to biology, then the potential of things is much more high. The evolution of the ceramic implant systems, it's happening now. And if we see the titanium implant systems, they are, from the prosthetic point of view, they are much more easy to use than the ceramic systems, implant systems. But hopefully in some years, the ceramic implant systems could be at the same level of the titanium ones, with all the research and the development that the brands are investing. So during this presentation, mainly our focus will be on full arch, on full mouth rehabilitations, which is a life-changing treatment. And we have a lot of responsibility that when we are performing this kind of treatments, because we can change life of the persons for good or for bad. So it's better that we have a good plan to do in all the cases. And when we are treating this kind of cases, when we are rehabilitating full mouths, even above teeth or above implants, or say, I can say that even with dentures, we have the freedom to change the aesthetic and the function of our patients. Why? Because we can change the incisal edge display, we can change the occlusal plane, and we can increase the VDO, for example, and change as well the function. So, as you can see in this small video, this is the delivery of two zirconium final prostheses above zirconium implants, and we didn't touch we didn't grind anything. So you can see that with the full digital workflow, this kind of complex treatments became very, very predictable. So aesthetic and function, they should walk together in order to give our patients the best treatments. During this presentation, we will see three cases. And these three cases, they are very different. Case number one, we have the terminal dentition case. Case number two, we had terminal dentition as well, but with the loss of the crowns and the extrusion of the maxillar, the patient got without any prosthetic space. And case number three, we will see a full edentulous patient. This is the case number one, where you can see that the patient got several periodontal problems. Is missing as well some pieces, and the pieces that are in mouth, they got mobility, and you can see that the patient doesn't have a good hygiene compliance. So this will be the case number one, and in this case we will have a FP1 approach, and this we'll discuss further on. On case number two, it's a case with completely loss of the crowns of the teeth, but as you can see, the roots were maintained, and due to this, the buccal volume was completely maintained. And look what happened as well with the band of keratinized gingiva was completely maintained and attached, because we still have the roots in the bone from this patient. Case number three, which is the most challenging cases, it's a case where we have no teeth at all. It's a completely edentulous patient. So in these cases, we need to find some landmarks to help us to stitch our dates and join the dates together on the softwares. You know that the virtual dentistry and the full digital workflows, they need us to stitch and to superimpose the dates in some softwares. And this we'll discuss as well during our presentation. So the digital guided rehabilitations, we will use this concept in the three cases. In the case of the edentulous patient, the terminal dentition, and the vertical access. And why? Because this will give us predictability. We will know before the treatment what kind of prosthesis and what design of prosthesis we will deliver. We will guide our implants, and we will guide as well our prosthetic with the multifunctional guide concept that we'll see during this presentation. Even in cases like this that we have terminal dentition, this is much more easier than when we compare to total edentulous patient. But all of the patients, even or the patients with the terminal dentition or the patients that are completely edentulous, the desire, it's always the same. The desire is that in one shot, we can change their lives, and we can go from this initial situation to this second situation in few hours. And using the digital workflow and guided surgery, we can be less invasive, because mainly we use this kind of approach. And one of the indications, mainly indications for guided surgery, in my opinion, there are the flapless approach cases with the monoblock ceramic implants, because you need to be precise when you place your implant. Even more if your clinical approach is a clinical approach to delivery a FP1 prosthetic from the classification of Karl-Misch, because when you're delivering a FP1 prosthetic, you need to place your implant exactly on the emergence of the teeth, in the center of the teeth. Otherwise, you will kill the papilla between this and the neighboring teeth. When you deliver a FP3 approach or the FP3 design of the prosthetic from Karl-Misch, you are delivering not only teeth, but teeth and gingiva. And therefore, the position of the implants, it's not so critical that in the approach that you can see on the left side of the design. So you can see that, for example, in this clinical scenario, that the patient got several periodontitis as well, and you can see the extrusion of the teeth. This should be analyzed with conscience, and you need to take care with this analysis, because even in cases like this, when you can see that seems to be a massive destruction of the tissues, there is not. And in these cases, we are able to deliver as well FP1 prosthesis. Why? Because the bone is there, the soft tissue is there. What happened was the teeth that went out of the alveolus due to the periodontal disease. So our protocol is always the same. First, we go for data acquisition. The patient comes into the clinic, we take a CBCT of the patient, we do the intraoral scan, we do the photos and the videos, and then we put everything together on the Smile Cloud, which is a software that was developed by a good friend, Florin Kofar, which is dentist in Romania. I guess most of you will heard his name. So this software utilizes artificial intelligence to choose natural shapes of the teeth according to the face of the patient. And this is always our first step in planning a case, because this step will tell us what type of prosthetic we will deliver, because we'll have the perfect smile design, and then we know how far we are from the zenith of our teeth, from the gum and from the bone of the patient. So first thing is to have the design, and here you see the STLs of the final design of our patient, and now we know that we'll deliver FP1 prosthetic. So in this case, we will make the extractions, and we will discontaminate the alveolus. We will use guided surgery to place our implants in the perfect position, utilizing the ProGuide kit from Bredent Medical Company, which is a spoonless kit and a spoonless system. It is very practical and very precise system. So these were the final prosthetic, that the final provisionals that we were able to deliver, and in this way we can do this sculpture of the tissues and this design of the tissues. Why? Because we placed a two-piece monoblock implants, and we are able to change the height of the abutments and to change the design of the profile of the subcritical design of our restorations. And with this, we can shape these beautiful papillas and deliver these beautiful restorations completely integrated in the faces of our patients. And then you can see the preoperatory case and the postoperatory case, and you can see the complete adaptation of the tissues to our provisional prosthetic. And this accuracy, it's only possible when you're using digital workflows and you guide your implants and guide the position of your prosthetic. So a completely different scenario you can see on this case, that the patient has not only the periodontal disease, have some implants, some old fixed prosthetics, and has as well prostate bite, is a class 3 patient. In this case, you see that on the posterior sides, mainly, we have massive destruction and tissue loss. So therefore, since the beginning, we know that we will deliver FP3 type prosthetic to our patient. Even like this, we are able to deliver beautiful teeth and beautiful gums to our patient, and to correct the bite, the aesthetic, and the function only in one surgery with lots of predictability. Why? Because we are using this concept, the fully digital workflow with magnetical connecting guides. Maybe now we are not only use these magnets, but at the beginning, yes. And during the presentation, you will see what is this. We design and we construct a base guide where we connect the other guides in a sequence, and this will lead us to the final prosthesis in perfect position and in perfect occlusion with the lower jaw. So going further and talking a little bit more about what is the digital workflow and these digital concepts. For example, we developed this digital probe concept that allow us to measure the thickness of the tissue of our patients. And with this, we can plan more, for example. But in these cases, what we are using is this, the multifunctional concept guide. And what you are looking for now, you are looking for a printed model that in the base has one guide that is fixed with these horizontal pins, and to this guide will be connected with magnets to the implant guide, implant drill guide. This is what you are seeing on this picture. And let's see this in detail. First, we have when the patient got teeth, we have this tray above the teeth that will help us to positioning the base guide. Then we'll drill the bone, and with mini screws, we'll screw or pins will hold this guide in perfect position. This is the main guide, and if you fail in position this guide, you will fail in all of your treatment, because all the guides will be connected in this guide. And if this guide has some cant or is not in the perfect position, you will have a big failure. So I will advise you, and I will give you a tip. That's what I'm doing. When I place this guide, the best way to see if the guide is completely in place is to take a picture and to see it in the big screen. Because sometimes with the blood and the tongue and the cheeks of the patient, it's very hard to see if this guide is in place or not. So this is how I do it, and I will give you this tip. So this is the base guide that you see in the middle of the slide, and to this base guide we will connect the implant drill guide, and then we will have the final design of our prosthetic that will be connected on this guide as well, and we will connect this prosthetic design will connect this to our implants. Same for the upper and lower jaw. We plan all our big maxillary cases like this. So first thing to do when the patient comes to the clinic is the digital diagnosis. And how far can we go with this virtual dentistry? How far can we go with the construction of the virtual patient? First and foremost, we need the CBCT to give us the bone information, the intraoral scanner to give us the teeth positioning and the soft tissue information, photos and video, and the 3D face scan of the face. It is not mandatory, but if you have it, will help. But you can substitute the 3D face scan for a very good picture in frontal position of the patient. After this, after we have all these data, we can construct the virtual patient. And how far can we go and how precise can we be with this virtual patient and with this kind of approach? So we have two different types of virtual patients. We can have a complete 3D virtual patient that is only utilizing 3D dates, and we can have a 2D and 3D data merging of the dates. That's when we use, for example, scans, and we put like photographies in 2D together. This is the hybrid approach. The virtual patient we are using since many years. 12 years ago, we were using this 2D virtual patient to design our orthodontic guides and to plan how we move the jaws of the patients in orthodontic surgery. And this leads us to very predictable results in orthodontic surgery. That's why we are bringing these concepts as well to implant dentistry, because everybody was seeing that this kind of plannings will lead us to a very, very good result of pre and post-operatory to our patients. And this is a patient of orthodontic surgery. You can see that the facial result was amazing. The changes were amazing in the face and as well in the bite and the airway. You know that orthodontic surgery improves not only the bite, but airway and therefore the face of the patients. When we try to construct the virtual patient only in 3D, we utilize this kind of facial scanner with markers in the mouth of the patient that we can put on our softwares and superimpose everything in order to make the final designs of the prosthetic and the guides. So the strongest indications of the guided surgery, they are for flapless approach, for monoblock ceramic implants, when we are use PF1 approach, because we need to have the implants precisely where we want, and for segmented cases, more than else in the aesthetic zone. So what are the options when we talk about guided surgery? We can do reverse planning, digital reverse planning, and we can do it in with open source softwares, or we can do it on the planning centers. This is a matter of you find your workflow and see what fits better to you. So our protocol nowadays is to make almost everything in-house, to design the 2Ds in SmileCloud, and then we download, we construct our model on the mesh mixer, our 3D model with the natural shapes on the mesh mixer. And then when we have the final design, we design our guides. And for the guided surgery, we are only utilizing the ProGuide kit from Bredent Medical Company, which is a spoonless kit, very, very useful, very practical to use, because you have the spoon on the burrs, and we have worked from 8 millimeters to 16 millimeters, which helps a lot. So case number one, let's focus in the case number one, which is a case that has several periodontal disease. And first thing, we do the CBCT diagnosis and analysis. And when we analyze this CBCT, we see that we can place 6 implants in the lower jaw just to complete the dental spaces, and in the front of the lower jaw we make some extractions and some immediate implants. In the upper jaw we're planning to place at least 6 implants and to deliver a full arch immediate loading. But with what approach? The approach is what gives us the approach is the design. We can see that when we design the tooth, we have the tooth, and then we have the gums and the bone, and we don't need to reconstruct or deliver a PF3 prosthetics to our patient, because we still have conditions to deliver only teeth. And when it's possible to deliver only teeth, we are going to deliver only teeth, because it's more comfortable for the patients and more biomimetic. They don't feel any discomfort, they don't feel any volume that was not present on their mouths. So we put these patients on the virtual articulation because we are making a complex treatment. We always go for virtual articulation. We have the final design of the case, the final positions of all teeth, and then we design the guide. As you can see, we have this guide that will guide the provisional to the final place, and we'll left the provisional in the perfect place that we want for aesthetic and for function. So surgical approach, we went for immediate implantation in the upper jaw and some implants in the lower jaw. You see the base guide on the right side of the screen, and you can see the adaptation of this base guide to the tissue. This is what you should see when you place the guide and you take your photos before beginning the surgery. And we place 6 implants, and we have another view. And as you can see, with the monoblock implants, we don't have the chance to change the abutments. So we need to rely on this final position of the implants at the end of the surgery. This is the provisional for our patient, and for long-term provisional, we like to use HIPC, which is a high impact and concentration polymer, much more stronger than PMMA. So our patients don't have fractures of the provisional restorations during the integration phase of the implant. And this is the final aesthetic of our patients. In the next day of the surgery, you can see that has a completely integration of the smile with the face, the color of the teeth with the skin, the incisal edge display, the coral, the buccal corridors, and you see the adaptation of the prosthetic to the gums. What we see what you see that is a little bit narrow there, it's some hemostatic collagen sponge that we place inside of the alveolus, but they will heal and the tissue will be completely without any dark mark like this. So this is the post-operatory with 1 month, and you can see the beautiful integration. We lost one implant on the position of 42. Sometimes when we do immediate loadings, this happening. But as you can see, this loss of the implant does not occur with any infection. As you can see in the left side of the screen, we don't have any kind of infection signs. So it's a completely aseptic loss of the implant, and we open a small flap. We were able to replace this implant in a different position, but will not interfere with the final prosthetic. So for the final prosthetic, what should we deliver above these cases? First, we were utilizing these frames of zirconium above the zirconium implant, and we don't have bad results, but we are improving how we are delivering this kind of prosthetics. And we will see during this presentation in the final case how we are doing nowadays to protect our implants and don't have zirconium above the zirconium. So in this case, we delivered split frame in the upper jaw, and we delivered 3 split frames in the lower jaw, but we split the frame in the midline, and we connect the frame, we bond or we cement this frame to the zirconium implants. And as you can see, after 6 months of the surgery, we have beautiful integration of the tissue around these implants. Maybe if I can change my abutments, I will change my abutments in the anterior zone, so I will have a little better emergence profile of my teeth. But this is a completely acceptable result with a good shaping of the soft tissues and integration between soft tissues and the prosthetic. And our main objective, and whenever it's possible, this is our favorite approach to delivery a final prosthetic to our patients. So you see beautiful integration, the shapes of the papillas, and you can see the emergence profile of the teeth. It's very natural. And as you can see in the video here, we have a complete integration of the prosthetic with the gum of our patients. So the patient was very happy and we were very happy as well. So case number 2, this is a vertical excess case, and this is a very tough case. Why? Because this case can't be planned without be planned virtually. If you try to plan this case analogic, you'll see that you will fail. And let's look close at this case. You see that we had got no prosthetic space at all. And what happened when we try to make a mock-up to this patient? You'll see in the video in the right. The patient on the left, you see that the patient is talking with nothing on his mouth, and it's just showing gum, gum, and gum. And if you can see in the right side, the patient is not able to talk because the vertical dimension of occlusion is so high, the muscles are so stretched that the patient was unable to talk, and she can't have a good diction with the teeth and the jaws in this position. So therefore, this case can't be planned analogic, because you can't show to your patient the result when you need to reduce a lot. And when we need to reduce a lot, should our reduction be flat, or should our reduction be scalloped, like Maurice Salama showed us the scalloped guide concept? So let's see, always following the same protocol. And what will help us to decide and to choose the design of our reduction and our final prosthetic is the initial design that we always do on the Smile Cloud. So this is the protocol. We take a picture of the patient, we place this picture on the Smile Cloud, we make the design, and as you can see, we need to reduce a lot because this patient has vertical extrusion of maxilla during the loss of her teeth or the crown of the teeth. So after we choose the design, then the patient accepts the design, we download the shapes from the Smile Cloud, and we go from the 2D to a 3D design using this. And as you can see, when we integrate the design on the model of the patient, we need as well almost to cut half of the teeth. We need to reduce a lot. And this information, this we will only have if we are working on the virtual environment. So we know our design, and we know that we can reshape this bone and left this bone in the ideal position to hold the soft tissue and to give us beautiful papillas. So this was the design. Then with design, we choose the position of the implants, we design the guides, and we go for the treatment. And the goal of this treatment was to change the life of this patient in one day. So I fly into Germany because this patient was from a different country, and I've done this case in cooperation with Dr. Olga Schultz, that is speaking as well in the Congress, in this Congress. So we did this case together at his clinic in Lake Constance. We planned everything, we designed the guides, and we fly in just one day. We try to change the life of this patient. And as you can see, always following the same concepts. We have the base guide, we have the provisional that will be bonded or with magnets will be stuck in this guide, and we have the implant guide that will be stuck as well on the base guides. And in the upper jaw, we decide for a scalloped reduction design, and in the lower jaw, we went for a flat reduction design, delivering not FP1 but FP3 in the lower jaw with teeth and gums. And this slide, you can see the different approaches in the same case that we are talking about. In the upper jaw, we have the FP1 approach, and in the lower jaw, we decide to deliver teeth and gum to this patient and go for a flat reduction design. You see the guide, and you see that this guide is so thin, the guide for the scallop, that we had to mill it in metal. Why? Because if we just print this guide in normal resin, maybe we will have some breaks during the surgery. So this guide was milled in metal by my good friend Sergey Dutch, which is the dental technician who has made all of these designs present on this presentation. So the base guide, the implant guide, and the provisional, everything will be stuck in the same guide, so it's better not to fail the position of the base guide. And here you can see the difference between the scallop design of this base guide and the flat design of the base guide that we use in the lower jaw. And afterwards, we will connect the provisional and we'll cement this provisional on our monoblock ceramic implant. So we place the base guide, we open a flap, we place the base guide, and then we start our reduction. And then after the reduction, we start to place some implants, always in the same sequence. Having a protocol is always much more easier. And even if the guides are connected with magnets, it's always good to help with the hand to have good stability of the guides. We use this UV light to change the surface of the implants to turn the surface of the implants more hydrophilic. And we were using the new design of the implants, the tissue line design, which is very cool implant. As you can see, we have scalpel reduction. We left one part of one root there just to maintain the bony peak. And then we can see that we had perfect adaptation of the guides. This is the lower jaw. As you can see, guide, it's always a good idea. You see that the implants are on perfect position, in depth, and with perfect angulations. We cement the provisional in the upper jaw, and we make some sutures, and then in the lower jaw the same. And this is the result of at the end of the surgery. I guess it's a very pleasant result for a surgery like this, and for a girl that was living completely without the teeth. And even swelling, you can see that her eyes are completely shining in this state. She was completely emotional. As you can see, it's a completely emotional case with a dramatic before and after. So in this last 10 minutes of presentation, we will see the most challenging case. And this case is the case number 3, which is an edentulous patient with several medical implications. And for this reason, we went for flapless approach. First thing, when we put our dates into the software, we are able to start our design. And when we have the design ready, we can choose the position of the implants. Everything is planned according to the design. The position, the final position of the implants, it's always planned according to this first initial design, as we want to deliver as well FP1 type of prosthesis. We know since the beginning as well the density of the bone of our patients, so we can adapt our drilling protocols in order to have the initial stability that we need for these cases of immediate loading. So we plan the implants in the upper jaw. We design the guides. We have the same concept, this base guide, and in this base guide, we'll connect the provisional of the upper jaw. And this case, as another curiosity, that we have both provisionals connect in both base guides, and this will give us the final vertical dimension of occlusion of our patients. So in this base guide, we'll connect the implant drill guide, everything according and following our protocol, and same thing for the lower jaw. We have the design. After the design, we decide the position of the implants, and then we go forward when we design the base guide, the provisional inside and connected to this base guide. In the second guide, that will be connected with magnets. And then this will be disconnected and replace the implant drill guides, as you can see on the photos. And this is very precise because these guides were not printed or milled by Mr. Sergey. So this is our implant placement guides. As you can see, we have the vertical dimension of occlusion given by the both provisional connected to the guide. And now we'll see the video of this case, the surgery of this case. I will jump the initial part of the video in order to be inside of the time with my presentation. This was the part of the planning. And now I will explain how this guide will work.
So, this is our guide for today. We have the basal guide, and we have the implant guide that will be stuck with implants on the basal guide. And afterwards, we have the provisionals stuck in the same basal guide. In the beginning, we are going to use the provisionals and the vertical dimension reference to place both basal guides. As you can see, they have perfect.
And this is much more precise that we use a silicon index to place these guides because this is rigid and we have the vertical dimension of the patient that will lead us and will give us the way to position these guides. I will jump a little bit more the video. As you can see, we'll fix the base guides first, and then we will start drilling the implants. And I will jump because this part I can show you on the pictures. What I want to show you in this video, it's the final part that was amazing. Then after we place several implants on the upper jaw and after we place several implants in the lower jaw, we were able to connect our provisionals in the perfect position. Like that was some magic. That was not magic, that was just planning. And this shows us that we can rely on the digital planning and the digital environment. We placed the implants, everything was placed. I will jump a little bit more, all the implants with the stability that we want. And then in this part, we'll start to connect the provisionals in the upper jaw, and you'll see that we will be able to bring our mandible and to connect our mandible with some adjusts. But you see now, this is the moment of the truth, that we connect the provisionals in the upper and the lower jaw. And this is when we know that we were successful in our, we were really successful in our planning and in the execution of the planning. This guide is the spider guide that the Sergey and me has designed. This guide is very useful because connect all the implants with the rigid marks and we don't have distortion from the soft tissue. So we scan like a blast in the end of the surgery. And this was the provisionals that we left the patient at the end of the surgery. Not very beautiful provisionals, but enough for the patient can come out from the hospital to the clinic in 2 days and change the provisionals. These are the clinical pictures. You see perfect adaptation of the guides, one above the another. You see the implants were placed through the guides and with a completely right angulation. At the end, we use this spider guide to scan our implants. And same thing from the lower jaw, we place the implants. We scan the implants because in 2 days we will change this provisional for long-term provisional to our patient. And as you can see, always following the same protocol. This is the spider guides designed by Sergey Dutch. And this guide will increase the accuracy. And you see that not beautiful, but in the surgical theater, we are not able to reshape these provisionals. That's why we always do like this. We left this simple provisional in the mouth of the patient, then so the patient can come comfortable from the hospital to the clinic and change the provisional in the next days. This is the macro aesthetic of the provisionals, and as you can see, these provisionals were quite like the design that we had make at the very beginning of the case. Then at the end, we send the scanners to Sergey. He puts everything on the articulator, virtual articulator again, and he was able to superimpose the implant models to the initial design and to do the second provisional, which was a frame of BOHPC with some composite above. You see the design, and you see the superimposition of the first design above the implant models. So going further, the implant models, the superimposition of the guides, and the superimposition of the initial design. Then we mill the second part of provisionals, and then Sergey made a little cutback and made some art above this, and we have this kind of provisionals completely custom made and individualized. So this is our protocol for this case: smile design, guided surgery, and prosthodontics utilizing the White Sky zirconium implants. We made an immediate provisional. We used the ATP38 for photobiomodulation therapy. And this is 1 week post-op. Okay, and so you see that the patient comes into the clinic, we change the provisional during the week after the surgery, and we have a beautiful customized provisional for this patient. We check digitally the occlusion using the TEC scan as well, and you see the beautiful integration and the eyes of the patient completely shining. That was a success of treatment. So this is the situation that we had. 1 week post-operatory. This is our CDCT. Afterwards, we placed some short implants on the back of the lower jaw, and we wait for the integration of these implants. This is the video of the sequence of the treatment. We made the smile call 2D design. We transformed that on 3D. And after we place the provisional, we check the occlusion of our patient. And as you can see, we have almost the same forces of the bite in one side to another before we start the occlusion checking. So as you can see, at 8 months, we had beautiful integration, the keratinized tissue surrounding our implants, and we were able to deliver these final prosthetics in monolithic zirconium, just stained in the upper and lower jaw, a PF3, which has prosthetic as well. This time we improve, and we are not cementing anymore the zirconium to the zirconium implants. Therefore, we mill a BOHPP custom abutments, and we cement this inside of our frames, and therefore, and then afterwards we cement the frames on the zirconium implants. So we don't have any more zirconium above zirconium. We have zirconium, BOHPP, and zirconium, which will reduce a lot of the stress between the implants and the zirconium. You see the beautiful final prosthesis that Sergey Dutch delivers, the beautiful frame just stained, not ceramics. This is the beautiful of the digital workflow and to use this approach. We can mill and just stain and have these beautiful results, because the most important is not the ceramic, is the shape of the teeth, and we are using since the beginning natural shapes. I want to finish this presentation telling you guys that clinical competence, it is not enough for good results and to be successful. To be successful, you need to have communication skills and organizational systems. So your practice management and your team will be motivated and will have empathy. And these three bases together will lead you to clinical success. I will want to thanks to my team. Special thanks for Sergey Dutch for his partnership and for delivering such beautiful prostheses to our patients. These are my contacts. Feel free to write me if you have any doubt. I hope you guys enjoyed the presentation, and I want to send a big hug for the organization of the Congress, and looking forward to see you guys again soon. Bye-bye. See you soon.